Hola a todos, este bibliográfico se transmite también por el canal de YouTube, sección de intercambio académico virtual. Para colocar subtítulos en otro idioma, en este caso en español, seleccionen la barra donde esté indicada la flecha, habiliten los subtítulos que serán en el mismo idioma del video y luego modifiquen a través de la opción de traducción Auto Translate, seleccionando el idioma que deseen. En este caso podrán optar por la traducción del inglés al español. Recuerden tener paciencia, no es una traducción perfecta, pero sin lugar a duda será muy útil. Muchas gracias. ¿Qué tal si vemos un ejemplo? Fíjense cómo se selecciona, en este caso la opción de habilitar subtítulos, que por default serán en español porque ese es el idioma original del video. Luego volvemos a ingresar a esa opción, elegimos la opción del traductor y seleccionamos el idioma, que en este caso vamos a seleccionar el inglés y verán cómo los títulos cambian.
Okay, good morning everybody. We are as like every Friday with our early morning meeting for the Journal Club. Today we have the honor to have as an invited expert Dr. Adrian Bianchi, who is very well known by every pediatric surgeon in the world. Dr. Bianchi is an expert in neonatal surgery and especially in bowel surgery. And although today's topic is not directly related with short bowel and intestinal failure, which has been his main famous developments in surgical techniques. Of course, he's an expert also in enterocolitis, necrotizing enterocolitis, and so that's why we did this little invitation to join us. So everybody is welcome, and I leave you with the residents who will be conducting this meeting.
So good morning to everyone. My name is Luciana Lerendegui and I'm the current chief resident. Before starting our weekly journal club, please, we are going to go over some general rules. For the speakers, please turn off your microphones once you have finished your part of the presentation and avoid mentioning patients' personal information. For the audience, please turn off your microphone during the presentation, listen to the presentation carefully, and if you want to ask questions or comments, feel free to use the chat room. You can also raise your hand and you will be given time to speak. The topic of choice for this journal club is the timing of stomach closure in necrotizing enterocolitis. This is a meeting coordinated by Dr. Pablo Lobos, and the speakers are going to be Carolina Percul, Pedro Mercado, Ignacio Boyce, and myself. So let's start with our case presentation.
Well, good morning, everyone. To introduce the main topic to discuss, we are going to present a case, as always. In this opportunity, sorry, wait 1 second. Well, in this opportunity, the case is going to be about a preterm male newborn who was born before the 29th week of birth. He was, sorry, just let me a minute, like that. He was born before the 29th pregnancy week, and he has an intrauterine growth restriction, and he was born weighing 766 grams. He was product of a twin pregnancy in which his twin brother was dead in utero. As another antecedent, his mother had another previous pregnancy with a fetal death in the 27th week. At birth, he required mechanical ventilatory support for 24 hours, then turning to continuous positive airway pressure, and afterwards tolerating ambient air. During the 12th day of life, he presented abdominal distension and stooling after stimulation. The neonatologist decided to make this abdominal X-ray that we can see in the picture. The day after, abdominal distension went worse, So he was fastened, and within the next hours, he presented clinical worsening with enterorrhagia and went in coagulopathic. In that opportunity, he was reintubated. He required hemodynamic support with vasoactive drugs, and he required also multiple transfusions. In this next slide, we can see the radiological worsening that we could evidence in that few hours of that same day. In order to control this fast progression, we decided to repeat another X-ray some hours after that. This is the midnight scan. In the upper right corner of the slide, where the arrow is pointing, we can see free air. And with this finding, we decided to make an emergency surgery. The procedure was made in the NEC OR. A laparotomy was made in which we evidenced as the small bowel that was bile and a severe pancolitis with pneumatosis of the wall of the cecum and a perforation of the splenic flexure, which can be seen in the next slide. This is trying to represent the findings, and this is the perforation that we found in the splenic flexure. So considering the patient's status, we decided to resect the perforated segment, closing the proximal and distal segments of the colon without anastomose angle and using metallic clips. We also decided to make a divided ileostomy, which was made 20 centimeters before the ileocecal valve. During the first post-operative day, he didn't went better. He required increasing doses of inotropic drugs, high-frequency ventilation, and he went olivuric. The abdominal distension persisted worsening, and he added also a discoloration of the abdominal skin, as you can see in the picture. And he also, the lab also showed increased lung acidemia. With these changes, we decided to do another surgical exploration. We did another laparotomy, in which the small bowel persisted looking good and vital, and we evidenced a retroperitoneal hematoma and necrosis of the remnant left colon. So we decided to complete the left hemicolectomy, closing the rectum as a Hartmann, and also we made again an ileostomy. We made an end ileostomy 2 centimeters before the valve. This drawing is trying to illustrate the surgery. Well, after that, the patient didn't tolerate well the abdominal closure, which suggested abdominal hypertension. So we decided to leave an open abdomen using a sterile mesh. In the post-operative follow-up of that second surgery, it was favorable. And because of the clinical improvement, we tried almost 2 weeks after to decide, we decided to make the abdominal closure. In that surgery, the ends of the wound could be closed, but not in the middle. So we decided to use a Gore-Tex mesh, as we can see in the first 2 pictures. 1 month after that surgery, the patient presented a mesh infection. So we decided to remove it. And in the third picture, we can see the granulating tissue that was below the mesh. And after that last surgery, the abdominal skin kept improving and healing by secondary intention with no new complications. The patient gained weight, and after 152 days of hospital stay, 107 days of mechanical ventilation, and 49 days of requiring parenteral nutrition, he was discharged weighing almost 4 kilograms. Nowadays, the patient is 6 months of age. He's weighing almost 5 kilograms. He didn't present any new adverse events, and the ileostomy hasn't been closed yet. That is why he's the main case in this journal club, because we are going to discuss about the timing for stomach closures.
Okay, thank you, Carol. Now I'm going to talk about our experience in stomach closure in patients with NEC. For this analysis, we have reviewed all the cases between 2015 and 2020 for patients that presented clinical and radiological evidence for NEC. From the total number of patients with NEC, we have selected the infants that required acute surgical intervention. The key outcomes we analyzed include general population features, intraoperative findings, surgical procedure carried out, including type of stoma, and finally, time to stoma reversal and its complications. First, regarding population general features, infants were in average 16 days of age at the moment at their first surgery, and their median weight was 1,095 grams. From the 37 patients, 28 were submitted to laparotomy, while 9 underwent drain placement. From this last group, 5 were subsequently submitted to laparotomy, while the rest, 4 patients, did not survive. Excluding 2 cases where one died during laparotomy and the other whose bowel continuity was reestablished through a primary anastomosis, for the rest, we have 2 treatment options. One option is an in-situ resection with stoma formation, and the other, stoma formation only. So, considering all patients who underwent stoma formation, we have 31 patients involved. In terms of intraoperative findings during laparotomy, the chart below shows that jejunal was the most frequent segment involved with 42% of the cases, followed by total compromise of the intestine with 36% of the cases. And in third place, colonic disease representing 22% of the cases. Regarding ostoma location, no colostomies were performed, even though, as I mentioned earlier, the colon was compromised in 22% of the cases. In addition to this, continuing with the intraoperative findings, ileostomy was the most frequent type of stoma performed. Now, during follow-up, 10 patients died after laparotomy, while 6 patients are being assessed to restore intestinal continuity. Finally, 15 patients suffered stoma closure. They had a mean weight of 4,689 grams, and the time lapse between the first surgery and stoma reversal was 125 days. We have considered a cutoff for stoma closure of 8 weeks, as described in the main article that Luciana and Peter will be presenting in a couple of minutes. However, in our experience, in the majority of cases, bowel continuity was reestablished after 8 weeks from stoma formation. Last, but not less important, we analyzed post-stoma closure complications. From 15 patients that underwent stoma closure, 8 suffer any type of complication, regardless the timing of stoma closure. This includes bowel obstruction, anastomosis dehiscence, and intestinal fistula. Well, thank you all. Now Luciana will continue presenting us the main article.
So let's go over our main article. This is an article entitled "The Timing of Stoma Closure in Infants with Necrotizing Enterocolitis, a Systematic Review and Meta-Analysis." This article is a collaborative study led by Dr. Agostino Pierro. It was accepted for revision in May of 2016 and was published 1 month later that same year in the European Journal of Pediatric Surgery. As an introduction, authors recognize that necrotizing enterocolitis is in fact a devastating disease, and that often requires surgical intervention when perforation, clinical worsening, or unresponsiveness to medical management are present. There are some general universal principles regarding neck treatment, which are to remove the necrotic intestine, to control intra-abdominal sepsis, and to preserve as much bowel as possible. So, the classical approach for these patients is to resect the necrotic areas and to fashion a stoma. But sometimes stomas are poorly tolerated, and this is particularly true when we talk about sesionostomies. Also, there are no clear recommendations in the literature on how long to keep the stoma safely. Since the optimal timing for stoma closure remains controversial, authors for this study decided to set as a main objective to analyze if the time of closure of stoma impacts directly on patient outcome. In order to do that, they performed a systematic review of the literature and meta-analysis, using 2 independent investigators that searched through the scientific databases using a combination of keywords and inclusion criteria that are listed in the chart. The main target was to find studies that compare early versus late stoma closure, and those were the only articles included in the study. The variables that were analyzed were type of stoma, duration of TPN, length of hospital stay, and complications after surgery. They also decided to perform a meta-analysis, including only studies that had the same cutoff. They defined early stoma closure when bowel continuity was restored before the 8 weeks gap from the original surgery, and late stoma closure when it was performed afterwards. From the 505 abstracts that the investigators screened, only 22 were analyzed in detail, giving us a total of 6 articles, 5 of which were retrospective, and giving us a total amount of 280 patients or infants included in the study. Here are the 6 studies that were included in this paper, and you can see that only 3 of them were included in the meta-analysis because they follow the 8-week interval or the 8-week cutoff that the authors set as the point to difference early versus late stoma closure. Going over the main results from this paper, we can see that the commonest type of stoma was ileostomy. This was true in all 6 studies included. TPN duration was very similar in both groups, so they find no differences between TPN duration in early or close stoma closure. Length of hospital stay was not influenced by stoma closure timing. And finally, from the 3 studies included in the meta-analysis, which led to the analysis of 39 patients, they found that the complication rates had no statistical difference. So you can see that in the early stoma closure group, the complication rate after stoma closure is 31%, and in the late stoma closure group is 19% with a p-value of 0.5.
So this study shows that there is no influence on stoma closure timing, on outcome and complication, and we can see that there are several aspects of neck surgical treatment that are still controversial. Next, please. Next, please. So the literature on stoma closure in infants who had suffered from neck dates back to 1980s, where we can see some papers from 1982 where Rostein et al. They suggested that the bowel maximal adaptation is gained in the first weeks of stoma closure So they advocated to the early stomach closure to prevent chronic salt and water losses. And then in 1987, Gertel et al., they first conducted a prospective study on ileostomy closure as a way to reduce salt and water imbalance and long-term TPN dependence. So they said that early ileostomy closure was safe and feasible. And in 2012, it is a Dutch study where they performed the closure and they found no differences between postoperative adhesion formation, the costs of hospital stay, and the cost of surgical interventions. So they advocated for the early closure within the first 6 weeks of the baby of the same admission than the laparotomy. In 1985, Cogwell and Millikan, they were the first to report outcomes in stomach closure and in the patient that suffer dehydration, electrolyte imbalance, and acidosis, that were the ones that needed the early ileostomy closure. And then in 1987, Masmej et al., they found similar findings where the morbidity was unrelated with the type of stoma, the age, or the weight at the time of closure. And in 2015, in a North American study, they compared the stomach closure before and after 8 weeks. And they found that the TPN duration, they found no difference between the TPN duration and associated cholestasis, the duration of mechanical ventilation, and the incidence of bowel adhesive obstruction, and also in morbidity and mortality. And in 2009, Al-Huraif et al. In Canada, they performed a study where they put a cutoff in 10 weeks. And they could see that before the 10 weeks, and in the closure before the 10 weeks, they saw more time of mechanical ventilation, a longer total parenteral nutrition time, and a longer length of stay. Conversely, they saw the same survival rate and complication. So they advocated for the stomach closure that should be deferred until at least 10 weeks after its creation. Next, please. So this paper has a couple of limitations, like the different cutoff values of the different papers. And they could perform only a meta-analysis of only 3 of the papers, as Luciana said before. And they found that the postoperative complication rates were similar between early and late stomach closure with a cutoff of 8 weeks. Another of the limitations is the retrospective nature of the study, the small number of patients, and of course the differences in NEC management between 1980s and nowadays. So in conclusion, in infants operated for NEC, early stomach closure seems to be as safe as late stomach closure, and higher level of evidence is needed to confirm these observations. Thank you.
Okay, thank you very much. Congratulations to the 4 of you about the nice presentation and very well said in English. We thought about this topic for today's meeting because it is a usual point of discussion between pediatric surgeons and also neonatologists. When is the best time to close a stoma after a neck surgery? And I think that after going through the published evidence, we still don't have an answer for that, because as you all have seen, I think it's not easy to extract a useful conclusion from this paper and the revised published previous papers, because I think that probably it's a significant bias in the inclusion of the different groups of patients. When they say that early closure has resulted in prolonged stay, hospital stay, and PN dependence, it's probably due to that they were probably patients that were sicker, and that's why they were subjected to surgery earlier. And so probably the best option should be to do a prospective study, eventually a randomized study, which is, I think, not so easy to design. So we wanted to review our experience, our short experience through the last 5 years. And what we found is that in our hospital, and I think this is mainly due to the expertise of the neonatologist who works very close with us with this kind of patients. In generally, we didn't need to go in and reoperate the patients very early, as the electrolyte and fluid balance was not a significant problem in most of the patients. So Dr. Mariani and his team from neonatology in our hospital are present. So Gonzalo, if you want to make comments, and of course everyone discussion is open to make comments about the article and the topic, and then we will give the place to Adrian to make some comments and a short presentation. Gonzalo, ¿querés decir algo? Escuchamos, ¿eh?
Hey, good morning. I'm just arriving to the hospital. If you give me 5 minutes, I will be in my office.
Okay. Thank you. That's okay.
Thank you.
That's
Excellent presentation, by the way. Thank you.
Okay. Any questions from the audience so far? ¿Alguna pregunta en la audiencia? Usen
No.
por favor el chat.
No, I
Okay.
don't know.
Adrian?
Okay.
This is...
I have some comments.
Yes, please.
If you want to pass
Welcome.
a little bit of time. I can give you a clear answer, at least as far as I'm concerned, for when you close a stoma. If the child is having fluid electrolyte problems, nutrition problems, growth problems, then you need to think earlier. Although TPN, well done, without cholestasis, without heavy intralipid input, will sustain that child. Otherwise, wait until the child is stable, in good condition, and hopefully growing and feeding orally. Well, who is in a hurry? Why are you in a hurry? So run by what the child tells you. If he has problems and you cannot control, you need to go early. If you have no problem, the child is well, choose your time. Send him home if possible. Let him grow a bit. There is no best time in terms of numbers of weeks. And this meta-analysis is interesting, but beyond that, it doesn't tell us anything much. So those are the only comments that I wanted to pass in relation to the article. Over to you.
Thank you, Adrian. Dr. Torres from Chile is asking, when is our preferred time to do a stomach closure? I think Adrian has responded that question. Alejandro Peñarreta from Mexico is asking, does your team uses mucous fistula refeeding for ileostomies when distal segment is intact? Adrian, do you want to answer this question?
Well, if you
have a very well experienced that.
If you have a long tract of unused bowel, which is in good condition, and you want to make life more complicated, yes, you can use that. But you see, all of this problem that you are facing is all what I call salvage. You have a child whom you have managed to rescue. From your figures, 10 children died, yes?
Yes.
So ask the question, why did they die? Okay, now we can come to that if we have some time, and I will present what I believe as a management of NEC. But for the rest, you do the best you can, as you have done, and you use what you can to the best possible advantage of the child. So anything will do, but don't set out to set yourself a situation where you have a mucus fistula and then you want to feed a bit from there and the TPN on top. It just makes life very complicated.
We have been using, in some cases, the technique you described using as tube stoma for proximal ostomies, and in these kind of patients, sometimes we were able to do a fistula refeeding through the distal tube stoma, and I think it's a good option for this kind of very sick patients to preserve and to make the proximal intestine delayed. Do you have a comment on that? Are you still doing that?
Well, I agree with you entirely, and I do this sort of technique when I am forced, because I am late with other forms of surgery or other forms of management. So if I have a situation as you describe, yes, I will use the distal bowel for feeding and to keep it developed. More important than feeding is to actually develop the bowel so that when I join up, when I anastomose, it is already ready and active.
Okay.
And it helps the child rapidly.
Okay. Dr. Torres is asking, how much cholestasis do you allow the patient to have before closing the stoma? I know your answer, but
none at all.
Not at all. Yeah.
If you have, no, I'm serious. If you have cholestasis, which is a problem partly because of the serious sepsis and illness of the child, and largely because of the heavy intralipid load, you need to look at how you are feeding, what you are feeding, and revise your intravenous feeding. And more importantly, or as importantly, you need to look at how you are managing this child in the early time so that you don't get into this problem.
Thank you, Adrian. We have Dr. Puideval in the audience also, who has also a great experience in this kind of patients. Bebu, do you want to make a comment?
I already did it. I enjoyed what Dr. Bianchi said a few minutes ago, that the patient asks for the moment that you have to close it. We have means to decide when we do it, when there's a problem, but we have to respect the needs of the patient. And usually you hear me to repeat it, that the patient is who asks for the moment to close the ostomy. But I really enjoyed the way that simplified the moment to do it. If the patient asks it, the patient has problems, you have to close it. If not, you wait. You have to give time to the patient to be with the parents, to be outside the capital, to close outside of capital and see what's going on after that. Thank you.
Thank you, Bebu. We have another question here. When do you consider to do a primary anastomosis in a NEC patient?
That's a difficult one. In the present, with the present suggested management that most of the world is following and that you have quoted, the answer is almost never. Almost never, because the children, when the surgeon gets them, are usually in quite poor condition and quite septic. So it is not very safe to consider primary anastomosis. Better to put a stoma. So the real answer is, if the child is in very good condition and the bowel is in excellent condition, you can do a primary anastomosis after you have completely and totally deflated the bowel from mouth to anus and cleaned it out. And leave yourself a peritoneal drain. Otherwise, play safe. Don't do a primary anastomosis. Better to do a stoma and a peritoneal drain.
Yes, I think it's a little bit confusing when you look to the literature, because some of the patients that are described to undergo a primary anastomosis are in fact isolated intestinal perforation and not really neck patients. So in that case, it may be safer.
Well, in an isolated perforation, yes, there is no problem. The gut is healthy. You resect the perforation and you do a primary anastomosis. But that's a different condition.
Mm-hmm. When do you consider okay, what do you think about the role of laparoscopy in neck?
Nil.
It's clear.
I think you are playing with fire. Maybe if I have a moment, I can present my thoughts, and then you can carry on the discussion.
Yes, we will go to that in just in a few minutes.
Okay.
Dr. Braverman from Resistencia is asking about is making a comment about the periostomal skin is sometimes very damaged in this kind of patients. Do you have a tip for that, or how do you manage that?
No, I don't have anything special that I can tell you about that, except to try to avoid, to make your stoma in a manner where you can fit the bags and the protective materials that you use closely around the stoma to avoid the skin becoming macerated.
Yes, in some places here, it's not so easy for poor families to have the necessary equipment to bags and adequate bags, and also so in some places it can be a problem to discharge a patient with an ileostomy, with a high output ileostomy. Not so easy for families to manage them.
Well, in that case, you then have to think of an earlier closure.
Mm-hmm.
But bear in mind that if they have lost a lot of bowel and a lot of colon, you will transfer the maceration from the skin around the stoma to the skin around the anus.
Yes. Dr. Trigoso from Peru is asking, in which cases would you consider performing only a drain, putting only a drain? And in the case you do that, would you always go to laparotomy? And if you do that, how much time do you wait?
I can best answer that in my presentation.
Okay. And Lisandro Piaggio from Bahia Blanca, he's making a comment in their series. In your experience, what was your re-exploration rate or need for additional urgent laparotomies after creation of an ostomy? This was the case of our patient, and it's not so usual that we have to go in again after performing a stoma. Have you had patients like that?
Well, we all have had some patients like that, but they are few. It depends on what you do at the time of your first laparotomy. If you treat the bowel in the manner which hopefully I will have time to speak about, then you will not need to go back again.
Mm-hmm. Dr. Soto Rabelo from Dominican Republic is bringing a good point here. Some surgeons advocate to do an ostomy distal or after this more distal to the compromised bowel or some compromised bowel. Do you think it's a good option in patients who have a very, very extensive compromise, which had an obviously not necrotic bowel, to do not to perform a very proximal stoma, and instead of that do a distal stoma for decompression?
I think the important point here is decompression of all of the bowel. And then you have to decide where is the best place to put a stoma. But the key issue is decompression of all of the bowel from the mouth to the anus.
Mm-hmm. Dr. Torres is asking, is there an optimal place in abdominal wall to place a stoma?
Where is comfortable and convenient to put a bag on?
Yes, I agree with that. So if we have no more questions about this specific topic, I will allow, we will allow Adrian to make a short presentation about which is for you the best approach for management of NEC, which we agree that you have a very personal view on that, and we discussed it in your first visit to us in 2007. So please go ahead and don't worry about the time.
Okay, well, help me to get my presentation on screen. So if I do that, can you see?
You can share screen already.
Just share screen?
Yes.
You should be able to show the screen.
Is it showing?
Not
No, yeah.
Yes,
Yes,
it
now it
started. Yes, we can
Okay.
see it now. Yes.
What about when I do presentation, when I do slideshow? Is that showing?
Yeah.
Yes.
Yes.
You can go over your slides and we will be seeing that.
Okay, so you are seeing my slideshow now, yes?
Yes.
Perfectly.
We are.
Okay, thank you. So I will start. So this is my feeling and my view that I have formed over many years from seeing children with NEC here in the Royal Manchester Children's Hospital, St. Mary's Hospital, in the neonatal unit. They are treated primarily by the neonatologist. They did not come to the surgical unit directly. The first thing I want to say is, as far as I am concerned, it is not necrotizing enterocolitis, it is surgical necrotizing enterocolitis, because it is an acquired disease of a surgical nature. It is a small and large bowel disease where you have extensive bowel wall inflammation of necrosis. I will hurry because I don't want to waste your time. We know that there are a lot of predisposing factors, you know them, but the thing that I wish to point out, and you have seen it in relation to your own case, is that there is an association always in NEC with marked bowel distension. When the patient starts to develop the condition, there is always marked bowel distension. What is the impact on the bowel of the condition? There is a reduced anti-mesenteric circulation. And here you see a Doppler ultrasound showing you circulation that only reaches around the mesenteric half of the bowel. There is no circulation on the anti-mesenteric border of the bowel at all. And you can see why. Because it's dead. Because there is severe necrosis by the time that you have got to even doing your study. And of course, that leads on to perforation. If you see your case, the child got ill on the 12th day. He had a distended abdomen. By the 13th day, he was very ill, going on to ventilation, inotropes, such like, and perforation. Okay. Medical people, neonatologists, at least in Manchester, still manage NEC on the basis of Bell's stages, which were developed in 1978, not to guide when you should do things, but to document what happens in the condition. The surgeons still continue to treat the children on the basis of ideas that were formed in the 70s. So they would say to the neonatologist, tell us send us the patient when there is something we can cope and manage, an inflammatory mass. That is stage 2B. The formation of an abscess, stage 3A. Perforation, stage 3B, because then we know what to do, or we think we know what to do. Okay, and if the child survived, very often you had lots of complications. Fine. What is the impact on the child of this form of management, where the child starts to develop a distended abdomen, becomes unwell, still with the neonatologist, antibiotics, whatever else, inotropes, such like, but no involvement of the surgeon or surgery. The child develops severe septicemia, circulatory collapse, marrow depression, cerebral, and all the other problems that you know about. 30 to 50% of these children will die. If they survive, many will be healthy and well, and they will not have long-term problems, except for their scar or scars. Along the way, they may develop other complications, and also those which the doctor induces. TP and liver failure. We spoke a little bit about that already. Damaged bowel and short bowel, which you know about, partly the result of the enterocolitis and partly the result of the surgeon and neonatologist and the treatment that they have offered this child. Now, I don't say this to blame anyone, you know. I'm saying I have learned this over time, and which is why I have decided to change my ways. So the management of NEC is essentially prevention, if you can, question of what you feed, how fast you feed, and such like. Most people say if you are going to feed, use expressed breast milk, preferably fresh, but if you can't get it, then you use bank. But the problem with breast milk is that it leaves also a residue. Those of you who have gone in the abdomen of a child who has enterocolitis will almost always confirm that there are lots of milk curds that are causing a degree of obstruction. And if there was a perforation, you will find them in the peritoneal space. So milk curds in the bowel become occlusive at the level of the ileum. There is then fermentation with further gaseous distension, which leads to pressure inside the bowel loop and reduced circulation to the bowel loop. The best feed should be nutritious, no residue, and immunologically active. I'll skip on because there is not time. Okay, so the child with established enterocolitis is a septic neonate with abdominal signs. Now, this is when the neonatologist calls the surgeon. The surgeon goes to see the child. What does he find? A very sick neonate with features that are essentially abdominal. So the child started with abdominal features. If he could tell you that he had abdominal pain, I think he would tell you so. The nursing staff will tell you that the child had pain. Yesterday, you could move him about. He did not react. Today, you touch his abdomen. He pulls his legs up. He says to you, my tummy is sore. And then he gets abdominal distension. And then he begins to get all the other features of sepsis. I want you to forget completely enterocolitis. Can you do that for me for just a few moments? Take any patient of whatever age you like. Let us take a common child, a child of 4, of 6 years old. And he comes to you with a history of, yesterday I was well, then I started to lose my appetite, I got tummy pain, and it is now localized towards the right iliac fossa. And when the doctor palpates the abdomen, he finds that the child is tender, has localized peritonitis in the right iliac fossa. You have a suspicion of a common condition, an inflammatory condition, appendicitis, the equivalent of Bell stage 1, no perforation, just inflammation. What would you do? I don't know if anyone wants to answer me, but I will answer for you. I think you will all advise that the child should have surgery now and not wait until he develops, as we do with NEC, abdominal wall sepsis, an inflammatory mass and an abscess, perforation. So if this does not apply to other children, why do we insist that the child, the neonate who is vulnerable, who cannot speak to us easily, at least not in words, has to perforate, release feces into the peritoneum to dialyze through the peritoneal cavity against feces? It doesn't make sense. The aim of our treatment, if we start again, is to have a survivor with good bowel, without short gut, and with a nice abdomen that's not scarred, so that he has quality of life. Can we agree on that? When we see a child who is ill, we would like to have a child who is in good condition with good quality life at the end of his management. The management up till today has not been giving us this. 10 are dead of your series, and the others have stomas of all varieties with peristomitis and all sorts of things that you mentioned to me. Okay, my feeling is an unwell, at-risk small neonate baby who develops a tender, distended abdomen, Bell stage 1. Bell stage 1 for the neonatologist, okay? Who on ultrasound shows a ring sign. Now, ring sign is a sign of inflammation, hyperperfusion from inflammation. So the bowel is inflamed like that appendix I showed you and the cecum, but is alive. This child at this stage requires urgent consultation and surgery. When the bowel is alive, by the time that there is distension, lack of circulation to the antimesenteric border because of tension, it's too late. Bell stage 1, Bell stage 2. If the child is lucky, he will perforate early. The result of early perforation is deflation, a reduction of tension in the bowel with return of circulation to the deflated segment. So maybe some of it will pick up. Okay, so what do? You do the usual things, antibiotics, bone marrow supplements, whatever else, circulatory, respiratory support. What do you do with the gut? When you see the child, you start by doing an anal dilatation and a colonic washout to make sure that there is no distal obstruction in the colon, using air and soap solution. And I like to use Hib scrub, but whatever you like. If the child is not in good condition, you have seen him rather later, you have been caused rather later, it may be necessary to put a large drain into the peritoneal space and to do a peritoneal washout. And I like to do that with isotonic dialysis solution with added potassium in order to help clean the peritoneum, to dialyze against a solution and allow the child to rehydrate and correct his electrolytes. But now in this situation, we are talking of a child who has gone already beyond the best conditions. This is a child who is already quite severely septic, and you are trying to regain ground before you proceed to surgery. When you get to surgery, you need to open the bowel, do a controlled enterotomy if it is not already perforated, resect any perforated bits, of course, and then with a nasogastric tube or some type of soft tube, pass it up the bowel retrogradely and wash out the bowel from mouth to anus with a warm solution of soap and water and air. And you need to wash all of the small bowel out to be able to deflate it and collapse it. The result of deflating the bowel is that there is no tension in it, and so the circulation returns. And so the answer to the gentleman who asked about when you have extensive neck, but the bowel is not all perforated and is still alive, where do you put the stoma, is do an enterostomy at a convenient point if it is not already perforated, wash the bowel out and collapse it. And then you don't need to do any more stomas higher up or not, because when you collapse the bowel, you will see that it will slowly but steadily, before your eyes, start to go pink, if it is alive. So go have a cup of coffee. Come back 20 minutes later. The child will be in better condition, and you will see what is the condition of the bowels. And then clean out, of course, the peritoneum. And when you close, leave yourself a wide drain. Okay. For the very, very sick child, okay, there should be there it is. For the very sick child who you cannot even consider moving because he is so ill, so he is really almost dead, you cannot afford to try to do a major laparotomy because it will kill him. So in that situation, I will put a very large drain from the right iliac fossa all the way through to the left hypochondrium. And this is an intercostal 14 gauge drain through which I will then do peritoneal washout in the hope of improving the child's condition before laparotomy. Okay, so I will come to an end because I know time is rapid. So my message to the neonatologist in particular, but also to the surgeons involved in neonatal surgery, is that surgical necrotizing enterocolitis is a serious surgical condition. Therefore, it is important that the surgeon is involved immediately the child presents features that could lead to a more serious state. But it has an excellent long-term prognosis as long as the child has enough bowel, and obviously the less scars the better. So it demands a very close team approach. So you love your anesthetist, but you sleep with your neonatologist. Okay, so let us relate it to that which the neonatologist very often follows, which is the Bell criteria. So Bell stage 1 is the patient that you have. He has a temperature, he's beginning to develop abdominal pain, his gas pattern is changing, and he has abdominal features. You suspect that there is enterocolitis developing. Immediately you should have your surgeon with you and you consider what is the proper management. You do an ultrasound and you see that there is hyperperfusion. The bowel is alive. Okay, let us get there because live bowel is what we are after. Get to surgery, deflate all of the bowel and clean it out and clean the peritoneum. You do your ultrasound, you decided to wait. You repeat your ultrasound 2 hours, 5 hours later, and you see Y sign. Dead bowel, you are too late. Because you have not intervened to reduce the pressure inside the bowel to allow it to have a circulation. Okay, my final slide is this one, which I believe very strongly in. Today we are 2020, not 1977 or 1971 when I started. We have good neonatal care. We should have good team working between surgeon and neonatologist, not as I spent my life having to fight my way through. We have skilled anesthesia. So why do we need to operate without any light in the middle of an incubator, in the middle of a neonatal unit? If possible, we should operate in best conditions in a well-constructed operating room with good anesthesia. And given sensible, decent surgery, we have the best combination. My message to you all is, children do not die from surgery today. They do not die at operation. In fact, they do a lot better once you start to deflate the gut and clean them out and control their sepsis better. Live bowel means good quality life. No bowel means hell. But they die from lack of well-timed, appropriate surgery. So if you wait and you present the surgeon with a child who is already 3/4 dead from sepsis, with marrow depression, with coagulation problems, what do you expect him to do? He will try his best, but he will be in trouble, and so will the child. So time your surgery, do it well, and you will have a much better end result. Enterocolitis is a serious surgical condition that requires early, well-timed surgical intervention. Thank you.
Thank you, Adrian. Yeah, as always, you have a very personal view and a challenging concept for all of us, for surgeons and for neonatologists, challenging the usual practice. I think we are fortunate in our institution because our neonatology team involves us surgeons very early when a patient presents with abdominal distension and suspicion of NEC. And we all know that some patients will do well only with medical treatment. You have some stage 1, Bell stage 1, or some patients eventually may have some mild pneumatosis or we are not so unwell that could do well without surgery. So do you think that even in these cases, it is better to go in and operate them and so we are sure that they will not escalate to a sicker condition?
Okay. This is always the very difficult question, and it's always the one that the neonatologist tries to use as an outlet. I have no doubt, and I have also seen children who started off with a tummy that was tender, and then with antibiotics and conventional medical management improved. But I refer you to your presentation. You have 10 deaths. Do you want to take a risk? Because the risk is huge. The risk is of death, and if not death, short gut or severe reduction in gut. Against that, on the other side of the balance, okay, is that children do not die from well-timed surgery when they are in good condition, and the surgery can be limited and clean. So if this was my son and my child, what I would do would be I would want to see the child immediately with the neonatologist. Immediately the child starts to have problem. We put the child on the antibiotics, the usual medical management, and we watch very carefully hour by hour. If the abdomen becomes distended and the gut is distended and tight, then I want to go in quick. If I have the ultrasound that can help me, it's not everyone has Doppler ultrasound, it's not an easy technique, but if I have that to help me, then I can scan the gut every 10 minutes, every quarter of an hour, in the hope that I do not get ischemic gut. But otherwise, I would much rather have a well-timed minor surgery, laparotomy with drainage of the peritoneum and drainage and cleaning of the bowel when the child is in good condition, generally does not need inotropes, has a good blood pressure, is not severely septic. Then wait until such time as we have seen in your presentation and in the pictures that I have shown here. And I think everyone is familiar with the very sick child that we usually see.
Mm-hmm. Adrian, there's a question about chlorhexidine washout in the colon. Just to clarify that, you perform a colon washout at the neonatology unit before surgery, yes, or during surgery?
Immediately,
yes.
Immediately I see the child. Okay, I will clean out the colon. That's the easy bit. It's part of the immediate management. And then I have to decide if the child is in good enough condition to go to surgery, in which case I will proceed to surgery, or whether or not I need to put a peritoneal drain in and do peritoneal washout and a bit of dialysis to improve the child's condition before going to surgery.
Sorry.
Once I am in the abdomen, I will do an enterotomy and I will deflate the whole of the small bowel from duodenum to my enterotomy, and then the other way from my enterotomy to the anus to collapse all of the bowel. This also makes it a lot easier to close the abdomen because now there is not a distended bowel and there is no tension.
So you have no concerns about putting a chlorhexidine solution inside the colon in a patient who is not well and who is probably have an inflammatory situation on the colon and risk of perforation. You still do a washout with chlorhexidine? Have you had
Okay, two parts to the answer. One, I have no problem with chlorhexidine. If you have problem with chlorhexidine, I don't mind what you use soap, but use a solution that liquefies the material, not just saline, and use air, the same amount of fluid and the same amount of air, because if you put fluid only, it just flows out and it comes out clean and it doesn't detach the material from the wall of the bowel. So air and the soap solution of whatever variety you like. Perforation. No, I have no worry about perforation because for one thing, it's very unlikely if you do it with a nasogastric tube, a soft tube, and steadily, you will not perforate. And for another, if it does perforate, it's the best thing you can do for the child because he will deflate and he will salvage more of his gut. I was asked a question one time about putting a peritoneal drain into an abdomen with which is distended and tense and has lots of distended loops and perforation of the gut. Well, maybe that's the best thing you can do for that patient at that time, to perforate his gut.
Okay. We have another question. Do you use any any findings in the blood samples in the we say laboratory, but it's not the analytics? Have you find something useful there to guide your
I treat NEC patients as I would treat any, like I said, as I would treat any other child or adult presenting with abdominal signs. If I think there is peritonitis, local or general, preferably only local, suggesting inflammation, then my answer is you need a laparotomy. there are no real sort of indicators which say if you have a level so high of this or that or the other, then you do laparotomy or not. The blood tests are just electrolytes and such like to make sure that the child is in best condition. But from a diagnosis point of view, it is a clinical diagnosis aided by radiology and such like, and ultrasound.
Great. And I know you have a special concern about psychostatic impact of this kind of surgery in infants. What kind of surgical incision do you prefer now for the management of a laparotomy, an urgent laparotomy in this kind of patients?
Well, I try to keep in mind that the child who survives is going to grow to become a young lady or a young gentleman, and most adolescents don't like to go showing around very ugly scars all over the abdomen. So depending on the situation, the condition of the child, I will use either a phalangeal incision, or alternatively a periumbilical and a pharyngeal incision, or a transverse supraumbilical, depending on what is the circumstance. But I try to use the least possible, to leave the abdomen with the least possible ugly scarring.
Okay. I think we are very run out of time now, but I am sure that everyone in the audience, they are saying thank you for being here and for your great presentation and advice. And I would say thank you very, very much for visiting us at least through the screen. And I hope that you will be here visiting Latin America again very, very soon when this pandemic nightmare ends.
It would be a great pleasure. Thank you for asking me. My last comment, and I will go away, is live bowel equals quality life. Never forget that. Don't treat the child, treat the bowel.
Thank you. Thank you very much. Thank you very much. Gracias a todos y tendremos seguramente durante el día de hoy subido en nuestro canal de YouTube la presentación con la posibilidad de tener subtítulos en español para aquellos que quieran volverlo a ver. Muchas gracias. Thank you very much, Adrian. And I hope we will see again very soon. Bye-bye.
Bye, thanks.